invite Beijing Hospital. Can you pronounce this for me, Dr. Hu?
Yes. Okay.
Beijing.
Excuse me. Can I introduce my
yes, please.
the hospital first? Okay. Thank you.
Of course.
Okay. Hello, Norma.
Yes.
And Nivea. Nivea. Okay. We are very happy to have a meeting online with you. And our hospital belongs to Tsinghua University. Tsinghua University in China is very famous university. And but the medical education in Tsinghua University is very young. So our hospital, the history of our hospital just 7 years old. So now in our ophthalmology, the residency, residents, and not so many. So we have to, and we very like to learn from you and communicate with you to improve our resident level. In the future, we hope to communicate with you more and more, and on education and scientific research and clinic. And so we are very happy to communicate with you online. In the future, we hope we can communicate with you face to face.
Okay.
Thank you very much. Okay. So
it's a pleasure for us also to receive you here for the grand rounds. Okay.
Okay. Norma, can you introduce your ophthalmology to us?
Yes. Okay. The Department of Ophthalmology and Visual Sciences from our university, the Federal University of São Paulo, is a very big department. We have in doctors, ophthalmologists, considering all the services, we would have more than 200 working here at the university. So we have every year 10 residents. We have a 3-year program, and the 4th year is elective, and it's only in corneal transplantation. And after that, we have many post-graduation programs and also subspecialty like fellowships and in all the sessions. Rodrigo Brandt is with us. Would you like to say something?
Yes. Hello everyone. Hello Norma. Hello Nilva. Hello Dr. Hu. How are you?
Hello, Rodrigo Brandt.
Hey.
Okay.
Everything okay? Very early time, right?
Yes.
We have many post-graduation students from different universities doing the post-graduation here, but language is always an issue. Like sometimes we have Spanish speaking, English speaking, and we have nowadays more than 90 post-graduation students enrolled in the post-graduation programs. So it's a productive department, but still we always have to learn with you also. Thank you very much for being here.
Thank you very much. I know your university is very famous, so we are very honored to have a chance to communicate with you. Okay, can we begin our grand round?
Yes.
Yes.
Okay. Thank you very much. First, our resident is Sarah Lin. She is our resident in our eye center of Beijing Tsinghua Chang'eng Hospital. So he's a very young doctor. Please, Dr. Lin.
Okay, thanks. Hello, everyone. Well, good morning to Beijing and good evening to Sao Paulo. And today I'm very pleased to share a case about acute angle closure crisis, AACC, and how we diagnosed and how we treat it. The patient was a 76-year-old female patient who complained about vision loss with severe eye pain in her left eye after trying to wash out some dishwashing liquid in her left eye that accidentally got into her eye while she was doing some housework. The patient had unremarkable past ocular history or medical history. The ophthalmologic examination in the first evaluation, her first visual acuity was 0.6 in right eye and only hands movement in left eye. The intraocular pressure was normal in right eye and over 60 millimeter of mercury in left eye. No limitation of ocular motility, and there was nothing special in right eye except the peripheral anterior chamber depth was about 1/3 corneal thickness. And I'm going to show you the picture of left eye and fundus examination. So here is the picture of anterior segment of her left eye. And as you can see, she showed severe conjunctival congestion, corneal edema, shallow central anterior chamber. The peripheral anterior chamber at inferior and temporal side almost disappeared with obvious lens opacity. And the fundus examination was not clear enough, but we can still see that there was no optic nerve rim loss, retinal nerve fibrillary defects, or optic disc linear hemorrhage. So here, her ultrasound biomicroscopy also showed shallow central anterior chamber in both eyes, and the difference was about 0.7 millimeter. The peripheral anterior chamber depth in her right eye was not shallow with open angle. While in her left eye, we can see there was a forward displacement of the iris and lens. The peripheral anterior chamber depth was shallow and not even. The anterior chamber at temporal side almost disappeared with anteriorly positioned of lens, while the posterior chamber still existed. So we gave her IV infusion immediately of mannitol in emergency room, and her vision got better. The intraocular had down to 47 millimeter of mercury with deeper ACD, but things didn't change much after laser peripheral iridectomy, iridoplasty, and all the medication treatment. So after all the medical and laser emergency treatment, our primary diagnosis for this patient was quite clear. It was acute angle closure crisis, which is a sight-threatening emergency manifested as persistent high ocular pressure despite medical and laser treatment. And this is a simple sketch to explain. As you can see, since there is a complete obstruction of the trabecular meshwork by peripheral iris and a synechia angle occlusion, no aqueous excess is present towards the angle anymore. Instead, all the aqueous can only seep back into the vitreous cavity, forming these aqueous pockets, which increase the pressure of posterior segment and condensing the anterior vitreous and pushing the lens iris diaphragm forward. Basically, the situation is more like a preoperative malignant glaucoma. So now we know that AACC was caused by the failure of aqueous flow that through the pupil, leading to a pressure differential between the anterior and posterior chambers. But the reason for AACC was a little bit complicated. So first, we have to consider acute primary angle closure, supporting points including rapidly increasing intraocular pressure and angle closure in left eye, shallow central anterior chamber in both eyes, of course. However, the peripheral ACD in right eye was actually normal, and the unequal depth between nasal and temporal side in left eye are not provable for this. The second one is acute secondary angle closure associated with lens subluxation. The patient had a specific trigger that she was washing out some dishwashing liquid in her left eye before all the symptoms. and the unequal depths and the ultrasound biomicroscopy result showing lens anteriorly positioned, and the central ACD difference between two eyes also suggested abnormal position of lens. The most confusing part of these two diagnoses was that the central ACD was quite shallow in both eyes for this patient. So I did some research, and I found this article that showed that the ACD is much shallower, and the ACD difference between two eyes is a lot bigger in the lens subluxation than in acute primary angle closure. They had come to a conclusion that ACD less than 1.4 millimeter and ACD difference more than 0.63 millimeter are highly indicative of lens subluxation. And as for our patient, of course, the ACD in the left eye was only 1.15 millimeter, and ACD difference was 0.7 millimeter, all confirmed to lens subluxation according to this article. And for the third diagnosis, considering the rapid increasement of intraocular pressure, disappearance of peripheral anterior chamber, and especially there was no change of ACD after laser peripheral iridectomy, we had to think about malignant glaucoma. The aqueous misdirection of malignant glaucoma could be secondary to multiple clinical scenarios, including blunt trauma, central retinal vein occlusion, complete ring cysts of the ciliary body, and cataract surgery, also post-trabeculectomy. It starts with high pressure in vitreous cavity and ends to an overall anterior displacement of lens iris diaphragm. It should also include anterior position of the ciliary, but this patient first, she had no surgical or medical history as a trigger, and the posterior chamber still existed according to the ultrasound biomicroscopy image, so we can actually rule out this possibility. That means acute secondary angle closure associated with lens subluxation is more likely to be our definite diagnosis. And because anterior chamber of this patient had almost disappeared, so we didn't choose anterior chamber paracentesis, considering the possibilities of total disappearance and of anterior chamber and iris incarceration. Instead, we decided to perform a vitreous cavity paracentesis and anterior chamber reconstruction in emergency operation room. We did a pars plana paracentesis first to release the pressure in vitreous cavity, and we saw there was clear aqueous flowed out, and then we did a limpo-paracentesis to restore the anterior chamber, and by the end of the surgery, the anterior chamber was deep with normal intraocular pressure. And then we proceeded another surgery of anterior vitrectomy with phacoemulsification, cataract extraction, and intraocular lens implantation for this patient about 5 days later. And here is a video of the surgery. As you can see, after mydriasis, the equatorial part of the lens from about 3 o'clock to 7 o'clock was obvious, which also confirmed our diagnosis. So we started with anterior vitrectomy to deepen the anterior chamber so we could get enough space for continuous circular capsulorhexis and phacoemulsification extraction. And because of the range of suspensory ligament rupture was about 120 degrees, we used capsule capture fixation of intraocular lens. That means we place the optical portion of intraocular lens in the capsular bag and place the loop of intraocular lens in ciliary sulcus without any rotation. Here is a simple sketch showing that capsule capture fixation of intraocular lens. We can see the suspensory ligament rupture from about 3 o'clock to 7 o'clock. The green part represents the anterior circular capsulorhexis, and we place the optical portion, this yellow part, of the intraocular lens in the capsular bag, and place the loop, this blue part of intraocular lens before capsular bag, and put it in circular ciliary sulcus at about 8:30 and 2:30. And when we implant the intraocular lens, we make sure that there was no rotation to avoid any further surgical damage. And the intraocular lens could be steady enough, even though there was 1/3 of the suspensory ligament rupture. This is the first week after surgery. The patient V-reactive was 0.5 and the intraocular pressure was all normal in left eye during the anterior biomicroscopy. We can see a clear cornea, a deep anterior chamber, and the intraocular lens was in stable position. The last question I would like to discuss with all you guys is that different choices of emergency surgery for AACC. Would you only choose medical and laser treatment with observation overnight? Or what options can we do in emergency operation room? Should we just perform a paracentesis of anterior chamber or anterior chamber reconstruction and paracentesis or of a vitreous cavity, or even should we just go for anterior vitrectomy or phaco emulsification in emergency operation room? Or should we just wait for stage 2 operation when everything is more stable? What is the best way and best timing to release the pressure in vitreous cavity? Thank you, that'd be all for my today.
Okay,
Okay, so great. Thank you, Dr. Lin.
very nice, very good presentation. May I ask you the refraction, final refraction?
Final refraction.
Because visual acuity was 0.5.
Yeah, the visual acuity was 0.5.
And you know?
Without correction or with correction?
That is
Without-
definitely without correction. It's uncorrected
correction.
visual acuity.
Uncorrected.
Okay,
Okay.
Yes.
I see. That's a very good result, uncorrected, right? He might have some astigmatism, right, in this eye because of the lens
this
might be a little bit tilted.
no, it's very centered well, actually,
Centered
Dr. Brandt. This time in my memory, that's a little bit myopia for this kind of patient. Yeah,
Oh,
because you know, the AC is very shallow. That I think maybe the calculation, IOL calculator is not so accurate. After the ELP is changed after surgery.
oh yeah, for sure, right? It's an urgency situation, right? The IOP calculation is like the least important here for sure.
Yes, but the IOL is very centered. It's not tilted or decentered. This
Dr.
is
Lin,
my okay. You ask me?
considering UBM.
Oh, my resident, Dr. Lin.
Yeah,
my family name is okay.
Yeah, he's explaining, Norma, that their last name is Lin, so his first name
family
is
name is
Young.
Lin. Young, yeah.
Young.
Okay.
Like Doctor Who. I
Yes.
call him Doctor Who, but actually his first name is Dr. Yung Tao.
Yes,
Yeah.
you can call me Dr. Lin. It's much easier to pronounce, I think. Lin is much easier. Okay.
Yeah.
Dr. Aliman.
I would like to discuss only the UBM finding, because I agree. I saw the difference in the peripheral anterior chamber, and I also think it's related to the lens dislocation. But could you see the lens, the posterior capsule also, so you could have an idea of the position in vertical and horizontal meridians of the crystalline lens? Could you, or did you have this information prior to surgery? No. Okay.
Usually in my practice, we can't find the posterior capsule in UBM because the lens is always in China. The lens is a little bit larger and more like is thicker. It's much thicker.
Yeah,
So,
I know, but it depends on the machine of the instrument.
yes.
The UBM, you can sometimes in
sure.
some models see the entire crystalline lens. Okay, excellent. Rodrigo, any other consideration?
I would like to talk. I would
Yes,
like to talk about the ER, our ER service. We prefer to treat with medically, with monitor infusion and iridectomy and weight. We didn't do surgery with fake emulsification and vitrectomy inside the ER. In ER, we prefer to treat with mannitol and iridectomy, or even though trabeculectomy, and leave the lens for the second plan. And I would like to know about the other eye. Did you perform iridectomy in the other eye?
Yes, Dr. Morris. It's quite a good question. Actually, we do the emergent iridotomy for this case. Yes, you can do this in emergency room. Most time, I agree with you that we do the medical treatment, like the infusion or some eye drops, try to lower the pressure in emergency room. But if it doesn't work, like in this patient, I will do here. That's my routine. Our routine, we do the laser iridotomy in the emergency room. But for this patient, it doesn't work also. So if medical treatment it doesn't work, and if iridotomy doesn't work, what will we do in Brazil in your institute? That's my question.
Yeah, imagine we have a problem. It's the same thing.
Yes.
It's the same thing. The problem is our hospital, is how it works. Our emergency room surgical center, it doesn't have the capability to do phaco emulsification vitrectomy overnight. We can only do it in our operating room, which is across the street and only works on working hours during the week. So we normally don't do that overnight because we don't have the equipment there available like you have. Their hospital, they have everything in the same building, so it's very easy. So normally we have to treat medically first, like if it's in the middle of the night. And if you need surgery, normally you have to wait for the other day. So the other operating room opens and we perform the surgery, That's why.
But also, since the crystalline lens is the problem, UBM would be performed, and also the decision would be to do the surgery of the crystalline lens. Yeah, it's the same actually. It's only timing that may be different.
Okay, just wait. And how about AC tab? Do you do AC tab in your emergency room? I mean, AC tab,
we normally do it. If we treat medically, we do the mannitol, we do like Diamox, we do all the drops. And if the pressure doesn't lower above like 35, and normally we do the tap to avoid, the optic nerve to suffer more damage. But we use it as a last resort, only if all the medical treatment doesn't work. But sometimes we have to do it.
Okay.
But we can wait 1 day. The day next, the night, we can perform the surgery.
Okay.
If it is needed. Yeah.
Okay, got it.
Excellent. Let's move on, doctors. Let's call for the second case report of the night. Dr. Mengda Lee is the resident who will present.
Mengda.
Okay. Hello, everyone. I will share my screen. Can you see my screen?
Yes, excellent.
Okay. Hello, Professor Rodrigo, Professor Hu, and hello, everyone. I'm Li Mengda from Beijing Tsinghua Chang'eng Hospital, and today I'll present a case of intraocular mass provided by Professor Hu, and I would like to know what is your diagnosis. A 32-year-old male was presented to our hospital with vision decrease and superior vision defect of the left eye for 3 months. He had a history of low vision in the left eye following blunt injury by a fist 6 years ago. He has bilateral myopia of -2 diopters for 7 years. In a local hospital, the patient was diagnosed as retinal or choroidal mass, suspicious for malignancy, with exudative retinal detachment, and the patient was advised to have surgical removal of the mass and get an accurate diagnosis by pathological examination. So the patient was referred to our hospital for further treatment. On admission, examination of his right eye was unremarkable, and the left eye, his best corrected visual acuity of the left eye was hand motion at 15 centimeter, and the intraocular pressure was 13 millimeter of mercury. The slit lamp revealed mild anterior chamber inflammation with corrected precipitates, flare and cells of 1+, and relative afferent pupillary defect. There are also some pigmentations on the surface of the lens. Dilated examination revealed inferior retinal detachment and with the macular involved. In addition, there are 2 yellow-white masses in the nasal and superior quadrant with regular margin, and there are a new vascularization and hemorrhage on the surface of them. A magnetic resonance image revealed the mass as hyperintensity on T1 and T2 weighted images. Fundus fluorescent angiography and Indocinian green angiography showed blocked fluorescence corresponding to the lesions, and FFA showed mottled fluorescence leakage in the early and middle stage and the fluorescence staining in the late stage. So far, what is the diagnosis? Tumor, disease of inflammation or infection, vasculopathy, or hemorrhagic disease. First, intraocular tumor. Let's review several common tumors of the retina and the choroid. The first one, retinal capillary hemangioma. The feature of it is the tumor with dilated feeder arteries and drain veins. And the second one, retinal cavernous hemangioma. It has typical appearance of grape-like clusters of dilated vascular sacs. The third one, circumscribed choroidal hemangioma. It is an orange-red, usually solitary tumor situated in the posterior pole. The fourth one, choroidal osteoma. It appears as irregular, slightly elevated, yellow-white, just papillary choroidal mass with well-defined geographic borders and depigmentations of the overlying pigment epithelium. The fifth one, retinoblastoma. It is uncommon but highly malignant ocular tumor of the early childhood. It is a white solid tumor with calcium deposits. And the sixth one, choroidal melanoma. It is a solitary pigmented tumor presented as mushroom-shaped after perforating Bruch's membrane. And the last one, choroidal metastasis. It generally appears as a yellow subretinal mass, and bilateral multifocal metastases were most common secondary to breast cancer, while the unilateral unifocal metastases were more common with lung cancer. Did the patient have risk of choroidal metastasis? Chest computer tomography, ultrasonography, and male tumor markers are performed to rule out the possibility. Let's look back to the founders of the patient. It seems different from all the tumors mentioned about. Did the patient suffer from inflammatory disease such as VKH or Bisect disease? We made a detailed inquiry. He had red rash on cheek, back, and neck for 10 years, And as a 32-year-old male, he had white hair for 10 years. He also had sporadic tinnitus for 5 years. However, dermatology consultation suggested that his skin lesions are steatocystoma multiplex that is not associated by VKH or Bisect disease. And by searching the reference, steatocystoma multiplex isn't related with any ocular disease. And his fundus did not conform with the typical performance of VKH and Bisect disease. So inflammatory disease are ruled out too. How about infectious disease? The patient has no contact history with animals, and systemic evaluation were all found to be within normal limits. So infectious disease are not considered. How about vasculopathy, such as adult colds? There seems yellow-white exudation in the patient's fundus. However, unlike the cold exudation with irregular border that is distributed along the dilated vessels, our patient's lesion tended to be roundish in shape with clear boundary. So cold disease is ruled out too. Okay, so far, what is the diagnosis and what will be done next? We performed ultrasound B scan for him. On the detached retina, over high echo light bands surrounded anechoic area, and the two pictures are corresponding to the two masses respectively. Ultrasound biomicroscopy revealed peripheral retinal detachment with multiple small retinal cysts in chin, giving an appearance of a necklace. Yes, the masses are actually retinal cysts. So our patient is now diagnosed as retinal detachment with retinal cysts and proliferative vitreous retinopathy. We then performed a pars plana vitrectomy for him. During the surgery, we can see the whole retinal detachment. And this is the small cyst at 9 o'clock, and this is the big cyst in 12 o'clock. And beside to it, we can see the retinal hole. And then we performed retinal incision to drain the liquid out. We can see the liquid is yellow-white out from the cyst. And then we use photocoagulation to close the retinal hole and retinal incision. Finally, silicone oil tamponade was performed. We tested the cytokines in vitreous, which suggested inflammation within the ocular, but not lymphoma. And retinal histopathology of the mass showed a few broken keratinized epithelial cells with hemosiderin deposition, which confirmed the diagnosis of retinal hemorrhagic cysts. So our patient is finally diagnosed as long-standing rhizomatogenic retinal detachment with hemorrhagic cysts and proliferative vitreous retinopathy. 8 months after the operation, the retina was reattached, and his visual acuity has improved from hand motion at 15 centimeter to 0.16. Now let's review the disease of retinal cysts. Retinal cysts form from micro. Can you see the PPT?
No.
It's small, but you can finish.
Okay. Here, right?
Yeah.
Okay.
No, it's okay.
Retinal cysts form from microcystoid degeneration of the retina. They are formed in outer plexiform layer of the retina, and it can be divided into primary and secondary, and the primary is very rare. Retinal cysts with retinal detachment are secondary cysts, and retinal cysts are indicators of long-standing rhizomatogenic retinal detachment and seeing up to 1 to 3% of retinal detachment. And the pathogenesis of retinal cysts with RD is the outer layer of the retina with long-term detachment, like blood supply and the cystic degeneration occurs. The concentration of vitreous cortex causes the inner layer of the cystic degeneration to be pulled out and developed into retinal schists. And then the fluid actively generated in the splitting cavity form a cyst, and gradually it expands. Usually, retinal vessels are located on the inner layer of the cyst, and occasionally 1 to 2 branches are on the outer layer of the cyst. When the vessel ruptures and the blood gathers in the cystic cavity, a hemorrhagic cyst will form. Here are 2 pictures that are quoted from the references, and we can see the retinal cyst and its appearance of a necklace in the ultrasound B scan. Why was this patient initially misdiagnosed as intraocular mass in local hospital? Because his retinal cysts are hemorrhagic, especially in cases of refractive medial opacity. Hemorrhagic retinal cysts can be mistaken for retinal hemangioma, choroidal melanoma, or circumscribed choroidal hemangioma with subsequent enucleation. How to treat retinal cysts with RD? To the small retinal cysts, they do not require specific treatment except for surgical management of RD, and they tend to resolve on their own after retinal detachment. In the cases of giant or hemorrhagic cysts, which interfere with retinal reattachment, they can be drained surgically. So the last page is take-home messages. Retinal cysts form from microcystoid degeneration in the outer plexiform layer of the retina. Retinal cysts are indicators of long-standing retinosgenous retinal hemorrhagic cysts form when vessels on the cyst rupture.
Sorry for that. Wait, just a second.
Subsequent enucleation. Small retinal cysts do not require specific treatment, and giant or hemorrhagic cysts that interfere with retinal reattachment can be drained surgically. That's all. Thank you. Thank you for your listening.
Thank you very much. Thank you very much,
Great
Dr. Amanda.
case. Great
case.
Thank you.
Yeah, it's very hard to get like a retinal cyst with the retina is very normal, right? Normally we get those cysts when the retina is very degenerated, and the retina is still a little bit okay in the posterior pole, right? It was mostly in the periphery. That's why you fooled us all with this image. Really, it's very interesting, really.
These hemorrhagic macrocysts, they really can be mistaken by choroidal melanomas, even if they are really big and they touch the ocular wall during the ultrasound. Even the examiner can have the misdiagnosis, right? But
I think that this proliferative vascularization help us not to think about malignant melanoma. I think that the patient had a proliferative vascular tumor, so, because of the macrocyst. So I didn't think about malignant melanoma. I thought about proliferative vascular tumor.
I'm just saying
of the macrocyst.
when the whole cyst is has the hemorrhagic content, it's not this case, but you can have the misdiagnosis, even performing B-scan ultrasound. But then you have to check the connection or the base of the lesion, and you can see if it's not choroidal. It's not choroidal. So let's see. Dr. Michel Farah is with us. Would you like to make a comment? Or
just pointing something for our residents and fellows. What you see in this image in the upper section here, you see the figurative elements of the blood divided. You can see plasma over, the liquid part over, and like this level, red level is the hematic cells, because it's an old bleeding. So it's forming a level here. If you can see it, it's very horizontal here. So it's blood from a while ago. It's already liquefied, and you can see that it's dividing, like all the liquid over it, and all the cells, the red blood cells are under the cyst.
Yeah, for this patient, before the surgery, I refer to many doctors, because just according to the founder's picture, firstly, we cannot confirm the disease. So we just worry about the tumor in the eye. But after the ultrasound scanning, we can find in retina, other area, we can find retina cysts. So we think maybe this is the retina cyst. Actually, before the surgery, I cannot totally confirm this is the retina cyst. I also worry about the parasites in the eyes, because if the parasite in the eye, if we make a retinectomy, maybe induce the ocular inflammation. So so we sent the liquid from the retina cysts for the pathology biopsy, and it's okay. And this patient is lucky, no inflammation, and no lymphoma sign.
Which parasite you're thinking, Dr. Hu? Tapeworms?
Excuse me?
The type of parasite that you're thinking about, you think could be tapeworms or any other parasite?
No, I don't think so. Dr. Lin?
Yes, I'm here.
Do you have a comment about the parasite for this patient?
Yes, yes. First, Dr. Bryant, based on the picture, I didn't check this this case before surgery. I never meet this patient, but based on the picture, my first maybe impression is I have to rule out the infection, retinal infection, because of the, because the hemorrhagic retinal cyst is not, it's uncommon. For me, it's uncommon. We have some cases of retina cyst in chronic retina detachment, but the hemorrhagic is not so common. So I just think I should try to rule out the infection of some parasites, like the. So I ask the patient about his living, his working, his job. Maybe. So that's one of my questions. So I think just like Dr. Edelman said, maybe it's common. You have a lot of experience about this retina cyst. So,
but yeah,
is
okay.
it common?
No. It's not common.
I
Very
think,
uncommon, yeah.
according to my experience, I think, in my experience, I think this patient should be a long-term recommended genus retina detachment. The retina cysts, I have interesting for discussion of this patient is congenital retina cysts or secondary retina cysts. I think for this patient, because this patient have ocular trauma many years ago. So maybe the macular trauma induced the vitreous degeneration, maybe relation with this retina detachment. And the long-term retina detachment always or sometimes induce retina cysts. So this patient, the retina cysts, I think maybe come from the retina detachment. But the different in the peripheral retina, we also find small retina cysts in the peripheral retina. So on the other hand, maybe this retina cysts, yes, here in peripheral retina, we also find retina cysts. So maybe, do you think this cyst is congenital?
I don't know.
In many people, they have retina cysts in peripheral retina.
Yeah.
Not so many. Normally, like they have one or two. Those they had a lot, right? They look like, I can't say for sure, but they look like degenerative. I think he got this from a long-term retinal degeneration from retinal detachment. I think we can never say for sure.
Yeah, because it's different from pars plana cysts. They are cysts of the detached retina, right? It's not like the pars plana cysts. Rodrigo, did we listen to Michel? Michel Farah is here?
I don't know. I think he's online.
Yeah, I saw him, actually.
I think he's online.
Yeah.
Professor Michel is there?
Yeah. And Carlos Eduardo is the head of our uveitis service. Would you like to make a comment?
Yeah, sure. Actually, I don't feel like this is an infection condition. I don't see any inflammation signs, intraocular signs. And I'm agree with Brent. I think this is a secondary cyst. The unique uncommon sign is the hemorrhage, like in the periphery of cysts, but I still think this is secondary of chronic retinal detachment cysts. I don't feel like this is any kind of infection, any inflammatory condition.
Yeah.
Okay, thank you.
Thank you.
Thank you very much. Thank you, Dr. Mendele, for the presentation. Very good English from Dr. Mendele, and I forgot the name of the
Tyrolin.
Thank you.
Okay.
Excellent presentations, and
Okay.
we can move
Can we
on,
move on?
if you are. And please feel free to stay with us, or if you have to begin your routine. I know it's heavy there. Thank you very much.
Time for listening to all our cases?
Yes.
Yeah.
Yes. So let's go.
Let's go. So I call our resident, Guilherme Nício Novas. He will present. He gave the title anterior. Ready? I can see your screen. Okay.
Okay. Good evening, everyone. I'm Guilherme Nício Novas, resident of the second year in Escola de Medicina. And I'm going to go to the third case here from the Uvea division. My preceptor is Dr. Luisa Nascimento. The head of the division is Dr. Carlos Eduardo. And our patient is a 5-year-old boy, born and raised in Sorocaba, São Paulo. His main complaint, actually his parents complained of eye redness in both eyes, mainly in the left eye. And his parents also said that the kid was having some gait abnormalities for the past 2 months, like he was tripping over stuff in his house. He was falling a lot of times in his house, and even had some face bruises when he came to our service. For his past medical history, he had been previously diagnosed with hypothyroidism for the past 2 years. He was using levothyroxine, 25 micrograms. He was under good control of this disease. He also has been previously diagnosed with juvenile idiopathic arthritis with anti-nuclear antibody positive. And he was using methotrexate 5 milligrams a week, and along with folic acid. For his both past eye history and family history, both unremarkable. During his first ophthalmological exam with us, back in November 2021, he had an uncorrected visual acuity in both eyes of hand motion, intraocular pressure of 14 millimeters of mercury in both eyes. I'm gonna show the pictures of the anterior microscopy in the next slide. And Fontane's exam was impossible in both eyes due to media opacities. So this is the anterior microscopy of the right eye. He had a conjunctival hyperemia of 2+, band keratopathy, posterior synechia, 360 degree, and a white cataract. And he had no achievement. What?
Excuse me. Let's ask someone to help you in describing.
Oh, okay.
Okay. So I'll call Dr. Eileen Tabosi, if you can describe the case.
Yeah, sure. Like Guilherme was already saying, the patient presents a conjunctival hyperemia of 2+. This corneal opacity that looks like a band keratopathy, some posterior synechia, and also a cataract.
Yeah.
White cataract.
The patient had no white anterior chamber reaction, only have a flare of 2+, and no vitreous cells, and no keratotic precipitates. This is the left eye.
Right, so here on the left eye, you can see normal eyelids and eyelashes. I can see a conjunctival hyperemia of 2+. Also this corneal opacity that looks like a band keratopathy, formed anterior chamber, and also some posterior synechia and this white cataract.
Yeah, exactly. And also no anterior chamber reaction, although it was difficult to see because of the band keratopathy. Also had a flare of 1-2 crosses, and no vitreous cells, and no keratotic precipitates. So for the diagnostic hypothesis.
Wanna continue?
Yeah, sure. So we have this 5-year-old boy with a low visual acuity on both eyes and an important previous diagnosis of juvenile idiopathic arthritis. So of course we can consider that these complications can be due to this systemic disease. But of course we should also rule out some infectious causes like syphilis, HIV, and tuberculosis. But my main diagnostic hypothesis is juvenile idiopathic arthritis.
Exactly. So for the syndromic diagnostic, Eileen is right. We have bilateral anterior uveitis with posterior synechia, and we have to think as possible etiologies. First, we have to rule out every infectious possibility: congenital syphilis, tuberculosis, any virus from the herpes virus family, and after you rule out all those causes, you go to immunological causes, which can be HL, AB27 associated diseases, GIA, which is short form for juvenile idiopathic arthritis, BC disease, Blau syndrome, and tubular interstitial nephritis, uveitis. And also think about having in mind actually masquerade syndromes like lymphomas and trauma. We also point syndromic diagnoses such as cataract, band keratopy, and amblyopia, but they all secondary to our main diagnosis. So before we go, this patient, he had a triad of uveitis, band keratopathy, and cataract with posterior synechia. So when you see all these three findings in the same patient, we have to stand out to one particular diagnosis, which is juvenile idiopathic arthritis. That almost, frequently starts with all these three findings. So for the management.
For the management, considering this is our main diagnostic hypothesis, of course, like Guilherme said, we should rule out those other infectious causes. So it's mandatory to request some serologies and general exams. But because we couldn't see the fundoscopy, I would also request an ultrasound.
Exactly. So as Eileen said, we first go to the general exams and all serologies to rule out all the infections, and a tuberculosis skin test and chest X-ray. And I'm going to go straight to the point here and say they all came back negative, because this is not the point here. And also with an ultrasound imaging to see the fundoscopy, because the boy had both fundus exams with medial opacity. So this is a picture from the ultrasound of both right eye and left eye. The retina was attached. The patient had some macular irregularity in the left eye, probably due to macular edema, which is one complication of the juvenile idiopathic arthritis, and no vitreal signs of inflammation, which is important to us in cases like this. This is the second picture showing the same. So for the following management, we referred this patient to pediatric rheumatologist to control the primary disease, which is GIA, and she increased the methotrexate dosage, and she also introduced tumor necrosis factor antibody, adalimumab at 20 milligrams subcutaneous every 15 days. And for the ocular management, we proposed phacoemulsification without the implantation of intraocular lens, because in patients with juvenile idiopathic arthritis, if you implant a lens inside the eye, you run the risk of triggering much more inflammation and trigger synechia and so forth. So we almost never do it. There's some controversy in the literature. Some doctors put lens, but most doctors don't go this way. We start with OD first, the right eye, and ideally you have to wait like 3 months of no disease activity for you to operate a patient like this. But as our patient had the visual acuity of hand motions bilaterally, we tend not to wait this much because of the risk of amblyopia and so forth. And in the same procedure, we plan to perform this EDTA, which is calcium chelate to treat the band keratopathy in the fellow eye, for it to be easier when you go and operate the phacoemulsification as well. So we planned phacoemulsification in right eye. It was performed in February, and left eye was performed in April, and there were no setbacks, no complications. So here is a short video of the surgery of the right eye, which was the first eye operated. Here we go with the main incision. We do with keratectomy of 2.25 to get access to the anterior chamber. We're gonna go, let me just advance. So insert the blue dye to highlight the anterior capsule. That's normal procedure. Here, Dr. Luisa is performing the synechialysis, which I said before, there was posterior synechia of 360 degrees in this eye. This is a really important procedure in the surgery. Let me just go forward. So about doing the synechialysis, then she's gonna try to puncture the anterior capsule and lift the flap. But as the anterior capsule in this patient is very fibrous, she needed to use the venous to help with the capsulorhexis. And that is another part that was really complicated in the surgery. But everything went very well. Okay. So I'm gonna show the post-operative. This is the dynamic examination of the patient 1 week after surgery in the right eye. So he still had some anterior chamber reaction because of the surgery, obviously. Some band keratopathy, but you see no lens inside the eye. Okay. We perform also post-operatively macular OCT just to check for macular edema, because that's also a common complication of uveitis in GIA. This patient had no alterations in the OCT, no macular edema, everything was fine. So this is the follow-up. This was like 10 days ago when we last saw the patient. He had a corrected visual acuity of 20/30 in the right eye and 20/100 in the left eye, with about 16 diopters spherical. And I'm going to show pictures of the anterior biomicroscopy in the next slide. Intraocular pressure was stable during all the process, during all appointments. It's also known that glaucoma is also an important complication of uveitis secondary to GIA, but this patient had no problem with this pressure. So this is a follow-up of one week, 10 days ago, this patient, after surgery in both eyes. So he had a little bit of band keratopathy in the right eye, remaining keratopathy here. No lens inside. Some synechia is still forming, but the eye is much better. So before I finish, I'd like to say why I brought this case. So although this is a severe setting of uveitis in a GIA patient, this goes to show that this is a very emblematic case, because you can present virtually to any sort of ophthalmology in any clinical setting, like ER or outpatient facility or private appointment. And we must be aware as ophthalmologists to avoid all these complications, all these severe complications that the patient might have if it's not treated, all these complications that might fall upon the patient. And GIA and uveitis in children, pediatric GIA is the most common systemic cause of pediatric uveitis in children, and it's potentially modifiable if you treat it early and aggressive with corticosteroids and steroid-sparing therapy. And as we could see in this case, particularly, it requires the coordination of care among various specialists like rheumatologists, pediatricians, ophthalmologists, uveiologists, and to provide the best possible patient care and outcome. And it's also important to say that the joint disease and the eye disease are not synchronous, and the eye disease can show up before the joint disease, during the joint disease, or even like 20 years after the joint disease. And there's no correlation between also severity of joint disease and eye disease. So this is a proposed guideline for screening of patients with GIA. And this goes to show that one of the most important risk factors for the development of uveitis in GIA patients is the oligoarthritis form, which was the arthritis of our patient, female sex, which wasn't the case, and NAA positive patients, which was the case of our patient also. So if you have all these three findings, your frequency of examination is going to be much more frequent. Also, okay. So this goes to show just a short video of the patient, 2 weeks postoperatively of the right eye, just to show he matching drawings with colors and names. We have other videos of him playing video game, riding bikes, but we're not going to show here because we don't want to compromise the child's identity. So that's it. I want to thank the audience for listening. I want to thank Dr. Eloisa for providing all the data necessary for me to assemble this presentation. And I'd like to thank you also, Dr. Carlos Eduardo, for guiding me through the process and correcting all my mistakes during the process. Thank you.
So Dr. Carlos Souza.
Yeah. I don't know if Eloisa is there or I go straight to my comments. Can I go straight to my comments?
I think so. She said she couldn't come.
Okay, and so actually we are in front of a typical case of juvenile idiopathic arthritis. And especially this case, we have the three most frequent complications in this condition, which is the band keratopathy, posterior seneca, and cataract. So I just want to add some comments on top of what Guilherme has already said. The first one actually is alert to the general ophthalmologist, because normally what we have in this kind of uveitis is a clinical silent uveitis with a few symptoms. So don't expect your patients like any kind of complaint, even red eyes, we can not have this kind of signs. So we need to make sure that we can follow this patient in a regular basis, so that in order to find any kind of subclinical and intraocular inflammation, especially anterior chamber reaction. The second point that I want to say is about the treatment. So what we don't want in this kind of uveitis is what happened with this patient. So it had like a huge cataract and posterior seneca and band keratopathy. So we need to know our weapons, what our weapons are. So we need to know how to manage with steroids, with monomodulatations and medications, and even biological medications. So this is really important. And if you don't know how to manage this kind of patients, we need to refer them, and in order to prevent those kinds of complications. And the last point that I want to discuss is about, it's a very controversial, that is about the lens implantation. So it's really controversial, but we have in our service, in our sector, a tendency to not implant and the intraocular lens in these patients, because our experience is really bad. We have a huge odds of glaucoma and intraocular inflammation right after the surgery. But if you discuss, you have to do like a case by case regular conversations. But if you have this attitude, like to implant the lens, you need to make sure that you have like a strict control of the inflammation right after the surgery. So I don't know if you have any question. That's are my comments. I think Dr. Ana Luisa are with the hands up.
One question, Dr. Ana.
Thank you. Carlos, congratulations and for all of you that choose this case. But my question is regarding the treatment, the systemic treatment before the patient had the anterior uveitis with the synechiae and cataract. Would the systemic treatment prevent the complications of the cataract and anterior synechiae?
Yeah, sure, definitely. Yeah, if you can like manage the inflammation with like hard steroids or immunosuppressive agent, we can decrease the relapse times and decrease the inflammation duration of the intraocular signs of inflammation. So with this treatment, we can prevent those kinds of complications, Dr. Anna, for sure.
Yes, because most of the patients with this kind of disease will come to the ophthalmologist when they already have bad vision. So we already have the complications. So we, as an ophthalmologist, should aware the pediatricians of any kind of joint disease, to send the patient to an ophthalmologist to take a look, at least if they have inflammation, because as you said, the eye is clear.
Yeah.
You don't have a red eye. So nobody will think about an eye disease with this kind of patient.
Yeah, that's exactly why we brought this case today. It's really important to advise like even general ophthalmologists about this situation, because we don't expect any kind of signs in some patients in the beginning of the disease, and they came up with just huge complications, as we saw in these patients, like in the late disease. So it's really important to be aware of this situation.
Yeah, they recommend.
And also about
just
about the surgery. Yeah, just about the surgery, because we saw a venous seizure inside the eye, and we have to be prepared with kind of most accurate kind of instruments like vitrectomy, scissors, and other kinds of instruments, because sometimes you're gonna need an anterior vitrectomy too.
Yeah, sure.
Doctor.
Cadu, just a little, Norma, a minute. Cadu, I'd like to ask you about the pars planite uveitis, because when you take a case like this with total cataract and no inflammation, could I think about pars planite uveitis?
Yeah, we could, but it's not common with this kind of posterior synechia, the intermediate uveitis. So, but yeah, definitely you can have, we need to think about intermediate, and the ultrasound would be very interesting to differentiate, because in intermediate, we're gonna have like those hyperreflective points in the anterior vitreous, so we can make the different diagnosis.
As I
understand. The other question, and about the laser PTK for the corneal alteration.
Yeah,
because you use EDTA, but and a laser for this kind of opacity.
Actually, Luisa used this because it is in her partly private office, but in our sector, you do use the PPK laser for sure in our patients.
So, Cadu, can I have one question?
Yeah,
Cadu,
sure.
Regarding the surgical technique, you in the uvea sector, you leave the lens capsule in place, or you try to remove all the lens capsule in those cases where you normally don't put the IOL, right?
On posterior capsule axis, but we don't remove at all.
The posterior capsular axis, right?
Yeah, we perform
free the visual axis.
Yeah, actually, exactly.
Okay.
To prevent like the posterior capsular opacification.
Our invitees from Beijing want to make comments. Dr. Yontao Hu?
Yeah, thank you. Very good case. Can I ask a question, Carlos?
Yeah, sure.
Yeah. So for this patient, you didn't implant intraocular lens, yeah?
Yeah, we didn't. As I said, we have a tendency.
Yes. So in my experience previously, I think maybe about 8 years ago. So I met a very young girl, 6 years old. she suffered the same uveitis. And in other hospital, they implant intraocular lens at the phacoemulsification. So the anterior chamber inflammation very strong, and they induce the intraocular lens dislocation, iris sketching. Okay. Yeah. So for this patient, did you continue use adalimumab for this patient?
Yeah, actually, we've been following these patients, and he didn't have any signs of intraocular inflammation. But we refer him to the pediatric rheumatology, and he decided to increase the methotrexate doses, but he didn't get any biologic therapy till now.
Okay, so in my opinion, another girl, she, previously we didn't use the adalimumab. Steroid drops induce glaucoma.
Yeah.
So it's very bad. So I think that the adalimumab maybe is better for the young children.
Yeah, I have to take care with her steroids because it's the treatment, but is the problem as well. So we have like two different scenarios. We have a scenario in these patients that we are treating the complication of the uveitis, and we have a different scenario that we are treating the inflammation, the ocular inflammation. So in these patients, especially, we don't have like any sign of activity inflammation. So that's why we didn't like increase any steroids itself. Who did it? It was the pediatric doctor, and we just treat the complications. You know what I mean?
Okay. Okay.
We have another. The professor Xin Yonglin wants to talk. Wants to make a comment.
Yes, sure. It's a wonderful case. It's a challenging case for me. I think a very good presentation. So for this kind of patient, I mean, the secondary cataract with GIV. Actually, I always put lens inside at the end of the surgery. Even I did such a case last month. But for this kind of case, I think before surgery, we'd better to order UBM, try to rule out the cyclic memory. Sometimes there is a cyclic memory around the ciliary body. So for this kind of patient, all the time is the pressure is normal. It looks normal. But we think even we use steroids for many, many years, I mean, the pressure, the IOP is always normal. Why? Even there is anarchy around because of the like hypotony, should be hypotony like the cyclic memory developed. So for this kind of patient, my suggestion is you can order UBM before surgery. Yeah. And be careful to do vitrectomy because it's hard, it's very challenging to put trocar inside because of the memory. Sometimes when you put a trocar inside, then the lens dislocated. Sometimes. So be careful, do the vitrectomy, even the anterior vitrectomy through the pars plana. If you want to do, just use the corneal incision. I think that's my experience. So, but for me, I think we can put lens inside, but always put the lens inside the bag, not in the sulcus.
Yeah, for sure.
If you put lens in sulcus, I think many issues with later post-operatively. So, but for this kind of patient, actually the capsule is like contract a lot. During surgery, if you put lens, you will find that the lens is much bigger than the capsule bag. So that's a problem. So try to remove all the the cortex. And for me, that I will maybe I will try to dilate or to make the pupil larger before using the trypan blue or vision blue to to stay in the capsule. And yes, actually, sometimes we can find that there is some synechia between the iris, the capsule, or even the ciliary body.
Yeah.
So
definitely is.
So I think, yeah. So is the infliximab available in Brazil?
Yes, but you usually use adalimumab, Humira.
Okay. So what do you think that, what time would you stop the eye drops after surgery? I mean,
actually, we follow the patients. If it stopped like doing any kind of anterior chamber reaction, we are just drop the topical steroids.
Like you said, this kind of uveitis, they like the quiet uveitis or cold uveitis. I think maybe based on the AC reaction is not enough. Maybe sometimes it looks quiet, but if you stop the steroids eye drops, maybe the reaction is progress slowly. There is still some synechia after maybe 2 or 3 or even longer months.
Yeah,
I think.
Excellent. Thank you. Let's move on. I'll call Frederico Novaes. He will present the next case. It's entitled Bilateral Visual Loss with Posterior Segment Manifestations.
All right. Can you hear me?
Yes, perfect.
Okay. So good evening, everyone here in Brazil. Good morning to you guys in Beijing. My name is Frederico Novaes. I'm a second-year resident here at the Federal University of São Paulo. Today, I'm going to present a greyhound of the retina division. My preceptor was Dr. Zaira Nicolau, which I would like to thank a lot for her effort on this presentation. And the chief of the division is Dr. Mauricio Meyer and Dr. Nilva. So we have a 22 years old male patient, white, born in São Paulo, Brazil. He complained of worsening of his visual acuity in both eyes for 1 month. He reported sudden blurred vision in both eyes and was seeing a reddish spot with the right eye. On the review of symptoms, the patient had fever episodes of 38 degrees and chills in the last 2 months. He also had petechia in the lower limbs and lost 30 kilograms in the last 3 or 4 months. He also denied hemoptysis, urinary or fecal bleeding. He was under investigation with the hematology team and had no ophthalmological or family history. On his eye exam, he had best corrected visual acuity of counting fingers on the right eye and 20/160 on the left eye. The anterior biomicroscopy was normal on both eyes with eyelids and eyelashes without alteration, clear conjunctiva, transparent cornea, and wide and anterior chamber, and the patient was phakic. His intraocular pressure was 12 on both eyes, and I'm gonna show you the pictures of the fundus exam. Okay, I don't know if anyone will describe.
Yes, let's see. Let's call Guilherme Macedo is with us.
Good evening.
Hello.
So we have here the fundoscopy of the right eye. There is a pink of the disc with sharp margins, cut disc ratio of 0.4, normal vessels, this extensive pre-retinal hemorrhage in the posterior pole. We also have this intraretinal hemorrhage next to the temporal inferior arcade, which presents this whitish center. It reminds me and rough spot in a touched retina.
All right. Here we have the composite image of this right eye. We can see this big hemorrhage on the fundus. And also here we have another pre-retinal hemorrhage in the inferior arcade, major inferior arcade. This bigger hemorrhage is under the internal limiting membrane. As we can see, we have this double white sign surrounding it. And also we have some intraretinal hemorrhages here on the inferior temporal arcade. On the left eye.
Fluoroscopy of the left eye, we have a pink cup to disc with sharp margins, cup to disc ratio of 0.5, normal vessels. We also have this pre-retinal hemorrhage in the posterior pole, about 1 disc diameter, with some hard exudates superior to the hemorrhage. It seems to have some intraretinal hemorrhage next to the temporal superior arcade as well, and attached retina.
Perfect. All right, so for the diagnosis hypothesis.
So we have a young patient presenting bilateral hemorrhages in multiple retinal layers, and also this rough spot in the right eye. He also presents some systemic findings, the fever, weight loss. I would think obviously some hematological disease, as the patient is already following with the hematological department. So I would think about some causes of thrombocytopenia, as leukemia, for example. Other possible differential diagnosis would be Valsalva's retinopathy and also Terson's syndrome.
That's it. All right. So for the management.
So for the management, may I continue?
Yes, please.
Okay, so I would order some retinal multimodal imaging, but to improve the visual acuity, first I would like to talk with the hematological department and see if it's okay to undergo this patient procedure, as for example, a laser, YAG laser, to transform this pre-retinal hemorrhage in a vitreous hemorrhage, and as well make it easier to be evolved without any other procedure. If it didn't happen, I would perform a vitrectomy.
All right, so I'm gonna show you some pictures of his exams. Here we have the OCT of the right eye. We have here this internal limiting membrane and the presence of this hyperreflective material beneath it, which is the hemorrhage. And on the second picture, we can see this hyporeflective image. That's actually a blockage by the hemorrhage. And here on the left side, we can see the presence of this hyperreflective material beneath the inner internal membrane, and with posterior artifacts that makes it difficult to distinguish if there is an alteration on his external retina. On the next OCT, we can see, despite of the hemorrhage, we can see that his outer retina seems more regular. Here we have his fluorescent angiography on the right eye. We can see multiple blockades, hypofluorescences by blockage. And the same thing happens here on the left side, some hypofluorescences by blockage. So we performed some laboratory tests. His hemogram was normal, except by the platelets that were on the inferior normal limit. His myelogram was with some granulocytic hyperplasia, and he had a immunophenotyping with chronic myeloproliferative disease, and also a karyotype with the Philadelphia chromosome. With all this together, he had the diagnosis of leukemia. and we performed the egg laser on the right eye. And 7 days after the egg laser, we can see that the level of the hemorrhage is lower than on the right eye, and his visual acuity was improved of 20/80. And here we have the microperimetry 7 days after the procedure. We can see here on the right eye that the red spots where the patient cannot see, and here on the left side. With 3 months of follow-up, the right eye improved a lot. The patient was 20/25, and before the egg laser membranotomy, he was counting fingers, if you can remember. And on the left side, we just waited for the blood to be absorbed by the eye, and the visual acuity was 20/50 after 3 months. Here we also have the OCT of the right eye and the left eye. We can see here the internal membrane detachment, but the internal retina and the outer retina is preserved. And here the left eye is also preserved. Here the perimetry with 3 months of follow-up. We have a much better perimetry here on both eyes, with much more green spots on both eyes. All right, thank you very much for your attention, you guys in China, here in Brazil, and thank again, Zaira, for helping me with this case.
So, Dr. Zaira, Nicolau, can you make your comments, please?
Yes, thank you, Dr. Norman. First, I would say it's a great pleasure to be here at the Grand Round and congratulate Dr. Friedrich for his presentation. Regarding the case, I think I have two basic comments here, but the first of it is, I think the great take-home message here is, when you see a dense pre-hemorrhage like this, pre-retinal hemorrhage like this, the first thing we think is valsalva retinopathy, and it's not wrong to think about valsalva retinopathy, but some things we should take in mind, and you take the whole picture of the patient. When you actively asked the patient about his symptoms, we could see that he had other systemic manifestations. And this is important because a disease was behind all of this, and this disease is leukemia. So it's very important so we make the proper diagnosis and the proper treatment for him. And the other comment I would like to do is about our management, because there is another management we could also do here, and Dr. Guilherme pointed out, which is the vitrectomy, the vitrectomy, the surgery for this patient, the Persplana vitrectomy. But we had a very young patient, and vitrectomy also comes, and it has possible complications with it, such as cataracts, such as endophthalmitis, such as retinal detachment, tears, among others. So we chose for a treatment that was more non-invasive, that has rapid results and very good results. And in this case, we could see that the patient had improvement in his visual acuity, and he was very satisfied with his final visual acuity. And thank you, everyone. And if anyone would like to comment on also.
So, who else wants to make a comment? Nilva?
I'd like to ask Zaira, why the visual acuity of the left eye didn't improve so much? Why?
The thing is, on that eye, he had some places due to the hemorrhage that was before, that it was altered. So he couldn't reach on that eye the same visual acuity as he reached in the right eye.
Could you please put again the OCT, please, Frederico?
Just a minute.
Is he under treatment, systemic treatment?
Yes, he is. He is under imatinib mesylite right now.
So here's the first OCT, Dr. Newman.
No, put the last OCT at the,
Okay.
your. Could you please point? Yes. Could you please point of the alteration of the OCT, like the EPR, please? Could you point? Because I couldn't show to you.
So here we have the detachment of the internal membrane.
Yes, the left eye.
Oh, the left eye, sorry.
Yes. Point for me the lower. Yes, here. Yes. We have this alteration in the OCT that this visual acuity it will be 20/50 forever, because this alteration at the OCT is a complication of the bleeding. That's why we didn't like blood, okay?
So,
Yeah. Dr. Tao, please, yes.
I have a question. So for the left eye, you didn't use the ligament, yeah? Just waiting for the blood solved. So do you think if the blood in front of the retina induce the toxicity to the retina?
Yes, it's my opinion, yes. Rodrigo Branch?
So for this patient, we can say the last observation, the right eye visual acuity is better than left. Yeah.
Yes.
Yes, on his right eye was the one that we did a membranotomy. He got a 20/25 vision.
Yeah, so I think maybe for the right eye, you use the later treatment to make the blood resolve the fastly, and the left eye, you just waiting for naturally absorbed. So maybe the blood vessel induced a toxicity to the macular retina.
Yes.
Do you think so?
Yes, I think so. But the thing is,
so can we make the vitrectomy for the left eye, because this blood very close to the macula, so maybe dangerous for the laser treatment. But maybe we can make vitrectomy for the left eye.
Yeah, normally the vitrectomy could be the treatment for both eyes, right? But the right eye, we were very lucky to be able to resolve with a very non-invasive method. But that's what we think, Dr. Hu. We think that the blood is toxic for the retina, even if it's in the inner surface. You always think that it's probably in the blood in the outer surface. And the photoreceptors is more toxic, but there's always some inflammation associated to the bleeding. So that's what you're thinking. I think you're correct. When you have those macular hemorrhagic detachments of the ILM, we should try to do vitrectomy if it's very small, because using YAG laser, it will be very close to the retinal surface, maybe causing damage, iatrogenic damage. So we would go for a vitrectomy for sure. I think we thought it was very, very small, so we did observation, but that's something that we learn over time, right? Even in the inner surface of the retina, maybe toxic. Probably the next time we're gonna do vitrectomy for those eyes too.
Yeah. Totally.
So may I have some comments?
Yes, please.
Okay. That's a wonderful case. I think I have learned a lot. For this kind of, for Vassava retinopathy, like in the right eye, for me, I always choose vitrectomy, actually, because I'm a retina surgeon. So I just worry about if you do yak laser, maybe the hemorrhage will like spread in the vitreal hemorrhage. It takes a long time, like in this case, it takes 3 months to absorb. During this time, do you worry about maybe the blood will cause some induced increase of IOP?
In this case, he had the resolution of the hemorrhage of less than 1 month, really. We just put it a 3-month follow-up, so we could diminish a little bit the time here of the presentation, but his response was earlier than that.
Okay,
and the IOP control, you're completely right. We always have to do in our consultations the IOP checkup to see if anything is going wrong with it. He was pretty young, so his EPR cells usually work very well in response for this hemorrhage. But yeah, you're completely right. We have to always check on the follow-up everything possible, and IOP is one of them. The rise in the IOP is one of them.
Okay, for this kind of patient, I always talk with the patient that you can choose yak laser or you can choose vitrectomy. But if you choose yak laser, maybe it takes longer to let the vision recover. But you took vitrectomy, like you said, that's maybe the risk of cataract. So for this kind of patient, I always during vitrectomy, I try to left the anterior cortex, to protect the lens to maybe reduce the risk of cataract development. So I just want to ask Professor Brand, so do you do the complete vitrectomy in this case, or just to try to leave the anterior vitreous to protect the lens?
Normally, when I do vitrectomy, I always do complete vitrectomy. In those cases, if I'm worried, I try not to touch the lens, but if I'm worried I'm going to touch it, I try to dissect the anterior vitreous, doing a hydrodissection. I do a hydrodissection of the anterior vitreous to the Berger space using a hydrodissection cannula. It goes down, and then we can remove it. So I'm very aggressive with vitrectomy. I don't like to leave remnants of vitreous, and I always try to remove as much as I can.
But do you think that?
Okay.
Sorry.
Okay. Go ahead.
Go ahead.
I have another thinking. For this patient, this young patient, I think maybe this is the 3 months of the follow-up. I think maybe in the future, for a longer time follow-up, the left eye visual acuity may be increased. I see. So we should follow up for more time. Maybe if the left eye visual acuity increased, maybe for this patient we can observe and waiting for a sub naturally. So for this patient, we will get a good experience. Because
probably that may happen, yeah. That they may recover some vision, right?
Yes, the photoreceptor recovered. They need a long time.
Okay, we are on time. I would like to thank you again, Dr. Yung-Tao Hu, Dr. Si-Young Lin, and Dr. Rodrigo Brandt. Nilva, would you like to say anything?
I'd like to thank you both, Norminha, Rodrigo, all the people in China, and we hope to meet you again. Okay?
Okay, thank you.
And have a great day there in Beijing.
Hope to see you again. Hope
Okay.
see you.
Thank you so much.
Thank you.
Thank you.
Thank you so much. Thank you.
Thank you very much.
I've learned
Very
a
good
lot.
cases. Very good cases. Very good presentations. Thank you very
Yes,
much for your
very
discussions.
good, very good cases for us.
Okay,
Thank you so
Hope
much.
see you soon.
for sure.
Okay.
Bye bye. Bye bye.
Thank
all.
you. Bye.
Bye.
Bye, guys.
Bye.
Bye.